So it is my pleasure to introduce Dr. Brian McIver. And you can see he's very well established. He got his degree in Edinburgh. Then he went to the University of Vermont to get his PhD. He was an endocrine fellow at Mayo Clinic. He was an attendee there for, let's see, almost 8 years. He's currently at Moffitt Cancer Center down in Tampa. His focus has always been thyroid cancer and nodules. His research focus has been thyroid cancer. He's currently doing active research in molecular markers. He was Teacher of the Year 2009 and 11 at Mayo, and you've all heard him speak. He's an excellent speaker. He's often asked to speak internationally on this topic of thyroid cancer. And he's the founding member of the World Congress, a program that we heavily sponsored last year. So he's now Deputy Physician in Chief. He was the leader of the endocrine oncology group and head and neck surgery. He was interim chair for breast oncology. And before that, he was the associate chair of GI oncology. So all the things that we do at CBL Path. So this is the rest of the agenda for the next 2 days. I will turn it over to Dr. Brian McIver.
Thank you very much, Heidi, and thank you to both Dr. Uhrmacher and Steve Schlumpert for the opportunity to come and present at this, I think, really critical sales meeting for a sales force that has the potential to change the world. And certainly in the field of thyroid nodules and thyroid cancer, I mean that very sincerely. This is an opportunity to change how we manage one of the most common nodule problems, one of the most common types of cancer across not just the US but around the world as a whole. And while there are many, many challenges that we'll face over the course of the next 3 to 5 years as these visions come to fruition, including reimbursement, including a competitive landscape, including diminishing reimbursement for many of the activities that all of us take part in, I really do believe that the technology that I'll be discussing today opens up opportunities to really transform the landscape and better manage patients who in the past have had limited options. So with that said, let me just open up a presentation here. All right, good. So again, Heidi, thank you for the nice introduction. I have a long-standing interest in thyroid nodules and thyroid cancer clinically in the research lab. In fact, one of the earliest projects I ever set out to do when I was young and naive and had no money to do it was to resolve the issue of the indeterminate cytology. Other technologies got ahead of me and I was never able to succeed, but I have followed along from the changes that have gone on and been involved, as most of you know, in a lot of the research that has either supported or refuted some of the original validation studies for many of your competitors in this space. And so I feel that I have some justification to speak. Of course, there's all this introduction going on and we can't finish until we've started. And since this presentation stands between you and dinner and potentially wine, I feel that I should definitely get started. So let us start off by emphasizing that what I view, at least, as the sales team member's role. Many physicians and many other professionals view this as the typical salesperson. Okay? And I think it's fair to say that even today, in a lot of practices you go into, you're deemed to be the slimy salesman or saleswoman who's coming along to sell the used car. Okay? This is not my perception of what a sales team really does, and this is not my perception of what a sales team's value is. Instead, I regard a salesperson as a teacher. And I say this from personal experience from many, many years ago. As a very recent graduate from medical school, a brand new intern in Edinburgh, I was supposed to be the expert. And many of the patients I was dealing with had hyperlipidemia and had high blood pressure, and I thought I knew that field. But it wasn't until the Merck rep came to speak to me one day that I really began to understand how to manage blood pressure. I learned that from the rep. I learned how to manage hyperlipidemia from the rep, from the various drug companies. And these guys were not selling the drug to me, they were educating me. Okay? And I really do believe that the sales team works best by educating physicians, not by selling them on a test. You don't need to sell me a used car. Educate me about what the landscape is, and by natural extension, when you've educated me, I will understand where your product fits in that landscape, and almost certainly I'm going to gravitate towards your product. So in selling, it's really about educating and leading the physician down the logical path. So you need to be an informed group of individuals who's going to sell by educating, and you can only educate if you really understand the landscape. So what I'm going to do today, with no real apologies whatsoever, is to try and walk you through the background to the issue of molecular markers so you understand that landscape, and then we'll drill down into the details of the molecular testing that you have available at your fingertips and compare it to the other products on the marketplace and what the precise selling points become. But it's education first, not selling. So we start with a thyroid nodule, and this is the absolutely typical presentation that comes into my clinic 5 to 7 times a week. It's typically either a young or middle-aged, typically female, in this case 42-year-old woman, who presented in fact for a routine well woman exam and was noted to have the thyroid nodule that you can see right here in her neck. Okay, and this was obvious. It moved up and down like an Adam's apple in the wrong place. The patient had not been aware of it until the OBGYN did the physical exam. And this is the typical history of thyroid cancer, but it's also the typical history of benign thyroid nodules. These are completely asymptomatic, causing no symptoms whatsoever, not doing a darn bit of harm, but it's just a lump. And that's how we start off with these consultations. So what causes a thyroid nodule? Well, I'm going to list about 6 or 7 different possible reasons why you might have a thyroid nodule. And the first one is a simple cyst. And you can see here on this ultrasound scan, this black area here is an indication of a cyst, just fluid-filled and nothing more. And fluid-filled cysts like this are really just representations of what the normal thyroid looks like. This is a histologic section of a normal thyroid gland. Little follicles, these pink areas that you can see are called follicles, and they're like little soccer balls in 3 dimension. Okay, they're spherical, and they contain this pink stuff called colloid. Colloid is a protein on which thyroid hormone is made, and the cells that surround this, known as the follicular thyroid cells, make that colloid. That's their sole function, because they're making thyroid hormone and they're regulating how that thyroid hormone is produced. In between, I'll just mention in passing that there's also some other cells, these things here called the C cells. They come from a completely different organ, have a completely different function. They cause a certain type of thyroid cancer called medullary thyroid cancer, which behaves quite differently from the follicular thyroid cancers that will be the focus of what we talk about today. But this is the normal appearance, and you can see that this normal appearance kind of resembles something you would see pretty much every day if you did your dishes by hand, and that is, it resembles soapy water. Okay, this is soap. Now, if you've had experience of washing dishes by hand, I used to have to do that as a chore as a kid, then you've seen those soap bubbles sit. And when I got lazy and I was not really washing the dishes, and you let those soap bubbles sit for a while, they coalesce and they pop together and they form bigger bubbles, as you can see here. And those bigger bubbles eventually coalesce to form the biggest bubbles. That's what's going on in the thyroid when it's making cysts, because those little bubbles are coalescing. Sometimes it's an injury to the gland, sometimes it's inflammation of the gland, but this is a benign process of the coalescence of thyroid follicles into this bigger cyst. And sometimes those cysts can get very big indeed, but even when they're massive, they are rarely representative of cancer. These are completely benign processes, and we know that based on the ultrasound. We don't need cytology, and often cytology is non-diagnostic in this type of environment, because all you see is cyst fluid contents, some macrophages occasionally, but you're not really seeing the follicular cells. And this, if it's done right, would typically be a non-diagnostic cytology, and of course molecular markers are useless in this setting. This is a common phenomenon. It increases in frequency with age. It's much more common in women than men for reasons that we can speculate on, but we really don't know. And it is a completely benign process. So that's the nice one. What else causes a thyroid nodule? Autoimmune thyroid disease, sometimes known as Hashimoto's disease, is the most common cause of solid benign nodules, again typically amongst women, usually women in their 30s, 40s or beyond. Often it causes this more diffuse enlargement of the thyroid gland because the whole gland is inflamed. It's an autoimmune process. The gland gets big, but it also gets lumpy over time. And that lumpiness is a reflection of the inflammation and the hypertrophy of the gland that is caused by the thyroid gland beginning to weaken. As it weakens, it has to work harder. As it works harder, it gets bigger. And that process shows up on ultrasound scan as lumps. And once again, the nodules that you can see here is characteristically benign. On the American Thyroid Association classification, this is described as a very low suspicion nodule. Biopsy indicated if it's greater than 2 centimeters, according to ATA. But these things are almost always benign. And you can see it's a very characteristic appearance. It's got this kind of speckled appearance, almost like it's a moth-eaten appearance or honeycombed appearance to it, so-called spongiform. It's an injured area of the thyroid, an inflamed area of the thyroid that is benign. But when you do cytopathology on this, quite commonly you will see cellular atypia. Often when it's inflamed, you're going to see Hurthle cells. These are sick-looking cells that the pathologist will pick up and say Hurthle cells. Well, Hurthle cell to an endocrinologist is quite different from Hurthle cell to a pathologist. In the endocrinologist's mind, Hurthle cells equal cancer, and Hurthle cell cancer is a bad cancer. And so that gets everybody panicked. Whereas the pathologists know, the cytopathologists know, that often these things are a reflection just of inflammation. So if we see a nodule that looks like that, first of all, we'll try not to biopsy it, because of the possibility of indeterminate cytology. If we do biopsy it and we see Hurthle cells, we're not going to panic about that. But of course, if it is reported as atypia or atypia fluss or Bethesda III, now we have to figure out how to take it to the next level. How do we take it to prove that that is benign? And this is the first place in which molecular markers potentially have a role. Because if you see some Hurthle cells and cellular or atypia without nuclear features of cancer in a nodule that looks like that, chances are it's going to have negative for mutations. ThyroSeq will be reassuring, and this is something that can safely be watched. So you're beginning to see where the molecular markers can help us. Number 3, a hyperplastic nodule. This is a nodule that's a focal area of the thyroid gland that is enlarged. But this thing is quite distinct and different from a neoplastic nodule. Okay, a neoplastic nodule has cancer potential. A hyperplastic nodule is just like my biceps muscle. Okay, if I work it hard, I can pretend, right? If I worked it hard, then it would get bigger. That's hypertrophy of the muscle. If you exercise your brain regularly, the idea is that gets bigger too, I hope. That's hypertrophy of your brain. And so organs that are used a lot get bigger, but that does not indicate a cancer predisposition. Okay, the distinction between a hyperplastic area of the gland and a neoplastic area of the gland, neoplasm arises from a single cell that goes through a genetic abnormality that drives its growth. And that can be a benign nodule growing as a neoplasm with the potential for it to become cancerous over time. And that's quite distinct from these hyperplasms, okay, this hyperplastic area of the gland where the gland has just become more active and grown a little bit. These hyperplastic glands are stimulated by external forces typically. That includes TSH. As the TSH rises, as somebody becomes hypothyroid, the parts of the gland that can get bigger and swell up and become hyperplastic. If you have autoimmune thyroid disease like Graves' disease, which causes an overactive thyroid, then parts of the gland can swell up and become hyperplastic. In cases of iodine deficiency, which is uncommon in this country nowadays, but still happens in people who are following super healthy diets with low sodium and they're avoiding processed foods so they don't get supplemental iodine, that iodine deficiency can cause a goiter, a swelling of the thyroid, and within that can be lumps, which are hyperplastic nodules. There are also genetic factors which can drive this process. People who have an inefficiency of the production of thyroid hormone, so the thyroid has to get big and lumpy in order to continue to work. And in all of those cases, we're dealing here with something that is hyperplastic but not neoplastic. There's minimal or absent malignant potential. These things do not become cancerous. And, importantly for the topic of the day, they lack any of the mutations that drive the cancer. They're not being driven by a cancer phenomenon. They're being driven by an external issue like the TSH. It's quite likely these nodules will become autonomous over time. They start to produce thyroid hormone independent of instruction. So these so-called multinodular goiters that occur in this hyperplastic situation may eventually become thyrotoxic and need to be treated either with radioactive iodine or surgery, but it's not about cancer. Okay? The trouble with hyperplastic nodules is that they may have high cell content. So when the cytopathologist is looking down the microscope, he or she will see a whole bunch of follicular cells that look bland. They don't have any nuclear abnormalities, but there's an awful lot of cells there and not very much of the colloid. And so oftentimes that is read out as suspicious for follicular neoplasm. So if an endocrinologist finds this kind of nodule here, kind of an isoechoic nodule with blood flow within it, within a gland that is structurally abnormal and has multiple nodules, and they decide to do a biopsy, the ATA says if it's greater than 1.5 centimeters, you should biopsy this nodule. So you do a biopsy on it, send it off for pathology, suspicious for follicular neoplasm. We'll have none of the mutations that drive cancer because it's hyperplastic, not neoplastic. And therefore, there's an opportunity to avoid an unnecessary surgery in a patient who in the past would have had surgery for this nodule, and it would have turned out to be what they call an adenomatous nodule. Adenomatous, it looks like an adenoma, but an adenoma is a neoplasm. This is a hyperplasm, no malignant potential. Number 4 on our list, thyroid follicular adenoma. This is truly now a neoplasm. This is a nodule that started off with a single cell. It inherited an abnormality, or developed an abnormality rather, and that caused it to grow. And its daughter cells inherited that same abnormality, some mutation or other. That causes those to grow, and they divide, and they grow, and they divide, and they grow, and gradually you get this nodule forming over time in the thyroid gland. By definition, a follicular adenoma has none of the features of cancer. It doesn't have invasion, it doesn't invade blood vessels, it doesn't get outside the thyroid gland, it doesn't spread into lymph nodes or into other sites. It is technically benign, but it's driven by a mutation. It's a neoplasm. And if it's driven by a mutation and is a neoplastic process, then there is at least some potential for it to become cancer. Okay? And the risk of developing cancer depends on what is driving it. So in this case, a follicular adenoma can be caused, for example, by a TSH receptor mutation. Okay? TSH receptor mutations, actually relatively common causes of follicular adenomas. They will often cause these adenomas to start producing thyroid hormone. So occasionally you see somebody with what's called a hot nodule that's making too much thyroid hormone and they are thyrotoxic. That is a benign process driven by a mutation. The chance that a TSH receptor mutation will push this to become a cancer is actually relatively low. Okay? In fact, it's way less than 10%, probably less than 2 or 3%. These are benign nodules. But they are neoplasms, and they're driven by a TSH receptor. Well, it turns out, of course, that in ThyroSeq version 2 and 3, you actually measure TSH receptors. They come out and say there is a mutation of the TSH receptor. Well, that's very helpful to a physician who's willing to read the fine print. Because although that test is positive, it's not going to be cancer. Although that test is positive, and the patient probably needs some treatment for this, it's not treatment for the potential for cancer. It's treatment for a benign, autonomously functioning nodule that over time will make that patient thyrotoxic. Now, go ahead.
Sorry, Charles, just a quick question. The thyroid follicular adenoma, would that fall under NIFT-P?
Nope, I'm coming to NIFT-P shortly, but you're thinking along the right lines, okay? But the TSH receptor mutation drives benign neoplasms, okay, with a very low probability of malignancy. Now, the problem when simplistic people come along and say, well, how good is your ThyroSeq? And you quote 68% positive predictive value. You have to take this into account, because a positive TSH receptor is a positive mutation but negative for cancer. Okay? So by definition, when you pick this up, you have to interpret it the right way. It's positive for a benign process. It's not positive for a cancer. If you treat it as positive and that's going to predict cancer, it looks like a false positive reading for cancer. But it's not a false positive reading. It's just a reading that tells you it's a benign adenoma. And that's where some subtlety really exists in the interpretation of ThyroSeq. And when you're going out there and talking to physicians about this, there needs to be that clarity in your mind that some of these mutations are not associated with cancer. Some of these mutations are associated with benign nodular thyroid disease. Which brings me to the RAS mutations. These are amongst the most common of the mutations we find in these Bethesda IV category, these suspicious for follicular neoplasm category of cytology. And these RAS mutations have a tendency to drive both benign and potentially malignant thyroid nodules. RAS mutations are a bit like TSH receptor mutations, that they drive the development of the adenoma, and that adenoma grows over time. But the presence of a RAS mutation also allows that nodule to develop other mutations within the nodule, which can transition that nodule from benign into truly malignant. And that idea of an adenoma to carcinoma sequence is fundamental in our understanding of how thyroid cancer develops. This is very analogous to the situation with colon polyps, and we're all very comfortable with the idea that colon polyps begin as benign and go through sequential transitions to become cancer. And on that adenoma, benign, to carcinoma sequence, you have a series of steps and a series of evolutions, and if you catch it early enough and chop it out, you don't develop invasive colon cancer. Okay? The same is true with these mutations, with these adenomas driven by RAS mutations. They're going to be on that spectrum from adenoma with cancer potential all the way through to some kind of a cancer, but they're going to be acquiring other mutations along the way. And the beauty, again, of ThyroSeq version 3 is you can pick up not just the RAS mutation, but also some of the other mutations that it might pick up along the way, and get a much better idea of where on the spectrum this disease lies. So in our experience, a RAS mutation alone is an indication either of a benign adenoma, which we can treat adequately by taking out that half of the thyroid gland, or an early stage follicular thyroid cancer, or a NIFT-P, something that's on that spectrum towards a cancer but is only at the very beginnings of it, which, by the way, is also very well treated by taking a thyroid lobe and leaving the other half behind. For something like this to go on and become an invasive cancer, it's going to have other mutations. It's going to have a TERT mutation. It's going to have P53 overexpression. It's going to have an EKA1F abnormality. It's going to have a variety of these other things going on that you're going to pick up with ThyroSeq. So the ones you have to worry about with follicular adenomas that have mutations are the ones that have multiple mutations, because they're the ones that are going to be potentially invasive. They're the ones that are going to require a bigger surgery, and those ones you can identify on ThyroSeq, and you can recommend that the patient go through a total thyroidectomy, which is the appropriate treatment for invasive cancer. In our experience, and we've been using ThyroSeq version 2 since the first day it came out, and we transitioned away from the Asuragen product, and we've used version 3 since it was available. So we have several hundred of these RAS mutants in our database, and in every case where we've had a RAS-only mutation, it's either been a benign adenoma or a very early stage thyroid cancer perfectly adequately treated with a thyroid lobectomy. It's called a therapeutic lobectomy. Okay? You had a question, sir?
Would a very early stage thyroid cancer, clonal neoplasm, would that be considered that? Like the false positives for version 3 were clonal neoplasm?
Correct.
So would that be, what is the treatment for clonal neoplasm?
For a clonal neoplasm with a RAS mutation, lobectomy. And again, I would argue that is a therapeutic intervention. It's not a diagnostic intervention.
Right.
Okay? You're taking it out because it has the potential to develop into a cancer. Now, to be fair to the criticism of that, we don't know how quickly that transition occurs. We don't know if that's a matter of months, a matter of years, or a matter of decades. But we do know that it has that potential to drive towards a cancer. So if I have a thyroid nodule that has a RAS mutation, please take it out, because I would much rather deal with it now before it becomes a malignancy, rather than wait until it's acquired its P53 abnormality and is now a deeply invasive cancer, when my chance of curing it is much less. But this is one of the areas you really have to understand in order to sell this product and educate about this product adequately, that not every mutation equals cancer. That doesn't make the mutation false. It doesn't mean it's a false positive. It means it's actually detecting disease at an early enough stage when it is adequately treated with a minimal surgery. And if I had a choice of a lobectomy and leave the other half in my neck so that I can manage my own thyroid hormone without having to take thyroid hormone, where only one nerve is at risk from the surgeon, where my chance of hypoparathyroidism is 0, I'll take a lobectomy every time for something that is well treated by lobectomy alone. This is what follicular adenomas look like. They tend to be a little darker than the surrounding thyroid tissue. They tend to be quite even. They're not looking moth-eaten like the totally benign spongiform nodules of inflammatory thyroid disease. They appear to be solid. And I joke with my cytopathologist all the time. My cytopathologist is in the room with me when I'm doing the biopsies typically. So I always predict what she's going to tell me from the pathology. And if I see something like this, I can reliably say it's going to be Bethesda IV. And almost always, 90% of the time, I'll be right. That doesn't mean the pathology is useless. It certainly isn't. Because once in a while I'm wrong, something like this turns out to be a malignancy of some sort, so we got to know that. But for a nodule that looks like this, follicular neoplasm is kind of what we expect when it is follicular neoplasm. Applying the molecular testing to this cytology is helpful because it will tell me, is this something I can manage just by taking this one lobe? Or is it something that I need to manage by removing the entire thyroid and exploring the lymph nodes behind it? Okay. Follicular neoplasm, key issues. Growth is stimulated by mutations. TSH receptor mutation does not equal cancer. It equals autonomously functioning nodules, which ultimately will have to be removed. RAS mutation is a pre-malignant driver of cancer, which will sometimes have pushed that cancer into an early stage cancer. So RAS mutations deserve to be operated on. And these follicular neoplasms typically are solitary nodules within an otherwise normal gland, which opens up the real desirability of only removing a half thyroid if you can demonstrate it's a RAS mutant only. And in my opinion, adenoma should be considered as a precancerous lesion which deserves to be removed. It should be considered as surgical disease, in other words. But lobectomy, a therapeutic thyroid lobectomy, is the appropriate therapeutic treatment for that individual. Not a false positive, but a true positive for a pre-malignant lesion. Okay? So you can begin to see just how complex this terrain really is. And as you go out there and you're selling this product, you've really got to have an understanding of the nuances of what these individual mutations really mean and what they're telling the physician so that they can judge the treatment accordingly. NIFT-P, I'm sorry, Mom, you have a question?
That slide before is really, really great and super helpful. What is the treatment for if you have a TSH mutation alone on its own?
So traditionally, these have been managed with radioactive iodine. They tend to be hot nodules.
That's what you said.
And traditionally, those are sufficiently hot. They're making enough thyroid hormone that the rest of the thyroid gland is shut down. So the only thing that takes up the iodine is that nodule. And at least in older individuals, when that happens, it's amenable to radioactive iodine treatment in many cases. In young people, the typical treatment is thyroid lobectomy. But again, it's thyroid lobectomy without it implying that that's a cancer treatment. It's implying it's benign, autonomous, needs to be removed to prevent thyrotoxicosis or treat the thyrotoxicosis. So somebody smart mentioned NIFT-P. What is NIFT-P? This is a relatively new classification. It was just about 2 years ago when it was first really described and encompassed in the WHO classification of thyroid tumors. And it is a non-invasive follicular thyroid neoplasm with papillary-like nuclei or nuclear features. So NIFT-P, non-invasive follicular tumor with papillary-like nuclear features, okay, NIFT-P. This is an important one because when the pathology is done, the nuclei look a little funky. There's some nuclear atypia in these things. And it resembles some of the changes that go on with papillary thyroid cancer, which has very characteristic nuclear features. That's actually one of the reasons why thyroid cytopathology is so powerful as a tool, because classic papillary cancer has classic nuclear features which are relatively straightforward for an experienced pathologist to pick up. And most of those will be classified as Bethesda III cancer, in other words. This one, not quite such intense features. Sometimes it's got a little nuclear grooving, a little pallor within the nuclei, some of those features that kind of hint at papillary cancer without it being full-blown papillary cancer. So these things are often classified either as Bethesda III with nuclear features or nuclear atypia, follicular lesion of unknown significance, Bethesda III, or alternatively as Bethesda V, because they've got some nuclear features that raise a question about malignancy, but which are not enough to call it Bethesda VI true malignancy. In other words, suspicious for cancer. Okay? So Bethesda III or Bethesda V. Now, different pathologists will put that into two different buckets. In our institution, our pathologists tend to call these in the Bethesda III class. In Mayo, where I was for 18 or 20 years, they would put it into the Bethesda V class. And so as a result, we would land up with Bethesda V carrying a lower probability of cancer at a place like Mayo than we do at Moffitt. In our experience at Moffitt, because we're stricter about what goes into that group of Bethesda V, the malignancy risk in that category is high, 95%, almost as much as Bethesda VI. But that varies around the country. But whether you put it into a 3 or you put it into a 5, they're both indeterminate, and they both turn out to have a very, very similar molecular profile, which is that these things are RAS mutants. Okay? RAS mutations very commonly are drivers of these things. And just like we said earlier, RAS is a driver on a spectrum of malignant behavior from totally benign with cancer potential to aggressive full-blown malignancy. And the NIFT-P lies on that same spectrum. The NIFT-P, in other words, is another of these pre-malignant lesions, just like the follicular adenoma. All right? It has been misquoted in as important a publication as the New York Times, that this is a benign nodule. That's not what anybody said when this came up. These are not benign, okay? They're just not cancer, right? And there's a difference between being benign and being not cancer. These are lesions that are on the spectrum towards cancer. These are pre-malignant nodules. They're neoplasms. They're being driven to grow. They're going to acquire additional mutations. They are going to become invasive at some point in their career. How quickly, we don't know, but if it's in my neck, I want it out. Can we do it in a way that minimizes the harm to the patient? Yes. If we recognize that this nodule only has RAS mutations, then this will be perfectly adequately treated with a thyroid lobectomy. When the final pathology comes back as a NIFT-P, we can celebrate with the patient that it was caught before it transitioned into a cancer, and it was properly treated because we had ThyroSeq available to us, and we didn't have to push to a total thyroidectomy. The next step beyond this is where one of these things begins to develop a little breach in the capsule, okay, because it's beginning to acquire the abnormalities that drive it in the direction of a cancer. And that's known as an encapsulated or partially encapsulated, non-invasive, follicular variant of papillary thyroid cancer. And in the past, all the NIFT-Ps fell under this follicular variant papillary thyroid cancer. This is just one more step on that evolution towards a full-blown cancer. But whether it's technically a follicular variant of papillary or technically a NIFT-P, both of these things are perfectly well managed by a thyroid lobectomy, a therapeutic intervention to take out half the thyroid. And you can recognize them with ThyroSeq added to the indeterminate cytology because they will be RAS mutants only. And so once again, whether it's an adenoma or a NIFT-P, it's a therapeutic intervention. It is not a false positive molecular test. It is a true positive molecular test indicating neoplasm, and that's key.
Quick question for you.
Yes?
Before they came up with the NIFT-P classification, were they doing total thyroidectomies for?
For many of these, yes. For many of these, because they had some nuclear features raising the possibility of a papillary cancer. In many centers around the country, it was a total thyroidectomy, central neck dissection. And then it was called follicular variant of papillary thyroid cancer because that was the classification and everybody felt good about themselves. Right. But here's the distinction between a NIFT-P and an invasive follicular variant of papillary. Okay? Whether it's one or the other actually isn't that important because this type of invasion into the capsule of the nodule itself carries very little harm to the patient downstream. So minimally invasive follicular variant of papillary versus non-invasive follicular thyroid neoplasm with papillary nuclear features, either one of those, adequately treated by a lobe alone. So again, what I'm really arguing here is that the molecular profiling of these tumors allows us to tailor the treatment in a way that suits the risk the patient faces. Both the risk of malignancy, in other words, the probability that this is a cancer, that's what most people are talking about these days, but also the risk from the malignancy. How much of a risk does this cancer pose to the patient? Because if it's a low-risk cancer completely removed, you have perfectly adequately treated that patient and you don't need the completion thyroidectomy and you don't need the radioactive iodine beyond it. So in amongst this knowledge of how the spectrum of mutations should be used to interpret the cytology result, we also have to add a knowledge of the understanding of how the disease itself should be treated. And the ATA increasingly has moved towards a much more precision approach to the management of thyroid cancer, where low-risk cancers get a low-risk intervention and high-risk nasty invasive disease gets the book thrown at it, so that we're matching the punishment to the crime. And that is where ThyroSeq version 3 really allows us to tailor the treatment for a precision approach.
Dr. McIver,
Yes.
have you seen a lot more lobectomies happening, from fellow endocrinologists around the country when they were usually doing totals, and now there's a lot more lobectomies because of the molecular markers, or is that not kind of happened yet?
Well, that hasn't happened yet, although I see an inkling that it's beginning to happen. And I think it's a really important question, because when it comes to managed care and gaining reimbursement, the question that's always going to be asked is, does the physician follow the recommendation from your molecular markers? Does the physician avoid surgery when the molecular markers are negative? Do they use tailored surgery when it's positive in the appropriate way? Do they use maximal therapy only for those at maximal risk? But this is a very new concept for physicians in the endocrine space, both surgeons and endocrinologists. And so until this publication for version 3 comes out, until we get this marketing up and running between CBL and Sonic, I think we haven't yet changed the direction that the Titanic is steering. It's still heading northwest towards the ice field. It takes a little while to change the course of the Titanic. So we published a paper just a few weeks ago demonstrating that when we applied molecular markers, ThyroSeq version 2, when we applied those in our setting, some of the decisions we made about how those should be handled were erroneous decisions in retrospect, and landed up increasing the number of total thyroidectomies we performed, because we were treating all mutations as equaling the potential for cancer. And what I'm arguing here is we needed to be smarter than that and recognize that some mutations actually indicate a low probability of cancer, or even when it is cancer, a low risk cancer, and they should have been treated with a much less aggressive surgery. So we have transitioned our approach to managing these mutational profiles to tailor the punishment to fit the crime. And I think as that becomes a standard approach, and you folks can help to educate physicians around this, you will see a swinging of that pendulum away from total thyroidectomy towards minimal intervention for low-risk mutations, and no intervention, just observation alone for those where you have no mutation seen. And that's the opportunity to transform the field of thyroid oncology.
You say that last two sentences one more time.
If I can. It's going to be on the tape.
Start with the pendulum.
Okay. So let me take a few steps back and I'll explain it in a different way. In the past, the approach that was taken was if you had indeterminate cytology, you would have a lobectomy. If the pathology revealed a cancer, no matter what that cancer was, you would go for a completion thyroidectomy and radioactive iodine. Basically a two-phase surgery and radioactive iodine for cancer, because we took a very much a cookie-cutter approach to managing thyroid cancer. What the ATA has recognized is that that is way too much treatment for way too many patients with low-risk malignancy. And so we are being asked to dial it back and do less radioactive iodine and do less surgery than we used to do for these minimal risk cancers. ThyroSeq can help us in doing exactly that by identifying the risk ahead of time when the cytology is not clearly diagnostic. If you have a low risk mutation, we have the opportunity to do a low risk intervention. In other words, if you have RAS mutant alone, lobectomy alone. If you have a TSH receptor mutation alone, either a radioactive iodine treatment or a surgery, you don't need to be thinking about cancer. If you have a BRAF V600E, which is equivalent to papillary cancer of the classical type, and it's a 3 centimeter papillary cancer, you're going to offer the total thyroidectomy. So precision approaches to the diagnosis allow precision approaches to the treatment of the disease. And that's where the power of this test comes in. It's not just about avoiding surgery. It's not just about the negative predictive value or the so-called rule-out test. It's not even just about a rule-in test. It's about a nuanced interpretation of the risk that cancer exists within that nodule and the risk the patient faces from that cancer. Risk of malignancy and risk from malignancy. And that's key.
Can you also talk about, a lot of times post-surgically, when they're doing the histology post-surgically, even though there was a RAS mutation, frequently that's going to come up because we were saying not as cancer on the post-surgical, but that's really not a false positive.
Yep, key. It's a key point that Brian's making here, is that we need to push back hard against the idea of false positive tests with ThyroSeq. If you find a RAS mutation, there's a very high probability that when that surgery is done, you're going to find either a minimally invasive follicular cancer or a NIFT-P, which some people call benign when it's not, or an adenoma, which is not yet transitioned to cancer. And that is all okay, because the RAS mutation guided you to a therapeutic lobectomy. It's a precancerous condition, which deserved to be taken out. It's surgical disease that you identified accurately with the combination of good cytology and ThyroSeq. That treatment is not a wrong treatment, and it's not therefore a false positive test. And we just need to get that clarity in. Part of the reason that we're having this conversation so intensely around this is because the waters have been muddied by, frankly, VeriCyte. Because what VeriCyte did was to take a very much binary approach. They took a classifier approach that said things will either be benign or they will not be benign. And anything that is benign doesn't need to have an operation done. That's going to save the healthcare system money. Anything that is suspicious by our classifier, you treat it like cancer. And so there was an awful lot of folks who were treating a positive GEC, the VeriCyte test being positive, as an indication of cancer total thyroidectomy. So in fact, back to your question a moment ago, there was actually an upswing in the number of total thyroidectomies being done as a consequence of the VeriCyte test. Because in the past, those individuals would have been investigated by a diagnostic lobectomy, okay? And the benign ones, they would have stopped right there. With the VeriCyte test saying there's a 40% risk of cancer when it's positive, that led to an increase in the number of total thyroidectomies being done around the country.
Clinicians tell me that when the VeriCyte test comes back positive, they go straight to surgery.
Yeah.
My next question should have been, what kind of surgery are they doing?
Precisely.
Which now I'm smart enough to have that conversation. But yeah, we've run into that a couple of times.
Yeah, and the pushback that I use all the time, and I discuss this with my patients all the time, because I still have patients come in the door saying, 40% chance of cancer according to this fancy genetic test, what should I do? My surgeon wants a total thyroidectomy. And I say to the patient, well, 40% chance of cancer, number one, isn't true, right? Because that's not, in fact, what the GEC classifier came up with. At most, it was 37%. So that's a minor variance, but it's important. So that means 1 in 3 chance it's a cancer. And it doesn't tell us anywhere where it is on that spectrum of being cancer anyway, even if we believe the study. And what we recognize is that not all cancers need to be treated with a total thyroidectomy. And I'll be talking about that again in a moment.
And then if they went for a lobectomy, suspicious affirma, then maybe they needed a total thyroid.
And that's really the reason why ThyroSeq is the superior product. Because if you can not just get a binary classification, but a nuanced classification of what that mutation really tells you, then it tells you how to manage the patient properly. A far more powerful set of information than just negative and positive predictive value, which is what is being sold right now. So the fifth cause of a thyroid nodule is thyroid cancer. And of course, this is what we're trying to identify. There are a number of different types of thyroid cancer. Papillary thyroid cancer in the top left is the most common. About 80% of all the thyroid cancers that are diagnosed are papillary cancers. Follicular thyroid cancer, Hurthle cell thyroid cancer, anaplastic thyroid cancer, which is a devastatingly dangerous type of cancer, average life expectancy 3 months. You're not going to be using molecular markers probably on those very often, but if you do, there'll be P53 mutations and TERT mutations and BRAF mutations. It's going to look like a mess. But these are the main types of thyroid cancer, and then about 5% of cancers are medullary thyroid cancer, which come from those C cells I mentioned earlier that are present in the thyroid but derived from elsewhere. They're neuroendocrine tumors and behave quite differently. But ThyroSeq is capable of picking up medullary thyroid cancer accurately, even if it shows up indeterminate. About 25% of all medullary cancers show up as indeterminate cytology, either Bethesda III or Bethesda III. And the medullary cancers typically show up on cytology as cancer, and somebody identifies they are truly medullary cancer, but about 25% of them turn out to have indeterminate cytology, either Bethesda V or III, because they've got some weirdness about them. The ThyroSeq assay will pick up the medullary cancers. Okay? It has the appropriate genes looking for calcitonin expression, and so you will pick it up. ThyroSeq version 3 will also pick up the vast majority of papillary cancers, as I'll show later on, the vast majority of folliculars. It will pick up virtually all of the Hurthle cell cancers. That's relatively unique to ThyroSeq. And anaplastic thyroid cancer will show up as a genetic mess, and so it will be picked up in ThyroSeq as well if it happened to fall into indeterminate cytology. So here's the big concern. Thyroid nodules are very, very common. 50% of adult women, 50% of women over the age of 50 have a thyroid nodule. Okay? And the older you are, the more chance you're going to find a thyroid nodule. It's about 30% of men over the age of 50 have a thyroid nodule. In Florida, where I practice, it's quite common to do screening thyroid ultrasounds. Okay? As part of the contract between the Hillsborough County fire department and police department and the unions of the firefighters and the police, part of that contract is that they get lifetime screening, which includes screening of their thyroid gland by ultrasound. So it's a steady supply of individuals coming into my clinic with a thyroid nodule found purely incidentally. And so the number of nodules we're identifying is rising rapidly because of that kind of screening test. And of course, coupled with that is increasing risk for thyroid cancer. The incidence of thyroid cancer is increasing more rapidly still than any other cancer type. In fact, it's slated within the next few years for thyroid cancer to be the most commonly diagnosed cancer of any type of cancer. Yes?
I've heard that people are thinking it's potentially due to flame retardants.
That's the reason that the fire brigade negotiated in their contract to get thyroid screening. Fire retardants, exposure to chemicals, there's a little hint of evidence around that, but we still don't really know. And the problem is, well, it may be environmental, but some of it is just case finding.
Okay.
Because what we recognize is that before we had all this ultrasound screening, those little papillary microcancers that were common in the thyroid anyway. A lot of tiny little things, perhaps 10% of adults have a papillary microcancer, which you can pick up when you do a screen with the ultrasound.
Right. So much like prostate cancer.
Very much like prostate cancer, exactly the same idea. And in fact, this idea is not unique anymore to thyroid or prostate. It's true about breast cancer, it's true about lung cancer, it's true about all sorts of different cancers that are things that look like cancer when you biopsy them, but they don't behave like cancer. So this increasing incidence of thyroid cancer is a combination of the discovery of latent cancer of that sort that would never have shown up otherwise, perhaps some environmental impact that truly is increasing the likelihood of developing a thyroid cancer, and beyond that, radiation exposure, certainly from the fallout in the 50s with nuclear testing, did increase the rate of thyroid cancer amongst adults in the Midwest and the eastern seaboard. So there's a combination of true radiation exposure, perhaps chemical exposure, and increased case finding. But whatever else is going on, this rapid rise is associated with an even more rapid rise in the fear that it's causing amongst people with thyroid nodules. Because people are reading about this, hearing about it, they learn they have a thyroid nodule, oh my God, it must be cancer. And they come in scared for their life. It's interesting, I mentioned this a little bit already, but thyroid cancer incidence is now heading towards the most common type of cancer in both men and women. This is the increase in incidence year on year between 2002 and 2011, and thyroid is right at the top in both men and women. So this is a very common problem. Your business is secure for many years to come, as is mine. It's already the 5th most common cancer amongst women. It will become the highest incident cancer, in other words, the most common diagnosed cancer by 2030, and the highest prevalence cancer by 2025. What does that mean? Because most of our patients live forever. Once we've done the diagnosis and we've done the treatment, they live a nice long life because they don't die of their cancer even when you can't cure it in most cases. So as a consequence, many of these, virtually all of these patients who are diagnosed with thyroid cancer are still alive. And so we've got this burgeoning pool of survivors of thyroid cancer. So my clinic is filling up with thyroid cancer survivors. Some of them now 25 and 30 years on from their original diagnosis, but still being followed because we know that long-term follow-up for thyroid cancer is necessary. So this becomes a real problem of numbers over time, and the cost of the healthcare system is vast. Of course, we love to diagnose thyroid cancers because we love to do biopsies. It's great fun. Okay, and we find a nodule, we find it on the ultrasound, we can do a biopsy in 15 or 20 minutes, and we can get biopsies done even into tiny little thyroid nodules. I mean, technically, I can steer a needle into a 5 mm nodule without any trouble at all, and I'm not even particularly skilled at this. So some of my radiology colleagues can biopsy things of 2 and 3 millimeters, reliably. Well, if you go chasing after that, of course, you're going to discover this vast pool of papillary microcancers that really don't matter to the patient, that don't matter to anybody, but they'll be diagnosed as cancer. And that's a problem. And so as the number of fine needle aspiration biopsies has continued to rise, and there's no sign that this is really slowing down yet, despite new ATA recommendations and changes in the Radiology Society recommendations, we're seeing now something like 650,000 biopsies per year in the United States being done. So once again, your business is secure. As we've done that, lo and behold, the cancer rate has increased as well. Probably, again, partly because we're identifying a pool of latent cancers that were going undiagnosed in the past that we're now discovering on ultrasound. And many of these, not all, but many of them, are very small cancers, less than 1 centimeter, papillary microcancers for the most part, which really shouldn't be biopsied in the first place according to ATA criteria now. We may see a downswing in that happening over time, but what is interesting is that not all of them are tiny. And you can see here the 1 to 2 centimeter tumors, which are real cancers which have the potential to threaten, but which are now being caught early. That's the real incidence increase, where we're actually adding potentially some value. And it's in that group, I think, where we have the potential for some further increased growth over time. But the bottom line is that I think ultrasound causes cancer, right? Because the more ultrasound we do, the more of these cancers we find. It's also possible, of course, that it's the CPT codes that cause cancer. Because at the end of the day, as an endocrinologist, this is the only billing I'm allowed to actually use to increase my income. I can only see so many patients if I can do a few procedures. One thyroid ultrasound guided biopsy and cytology makes me more money than 3 established patients seeing me in the clinic, and takes me 1/3 as much time. So you can imagine what the pressure is financially for endocrinologists to do this stuff. And that's legitimate and appropriate so long as they're selecting the right nodules to biopsy, they're using the right pathologist to interpret the cells, and that the interpretation of the cytology when it's indeterminate is guided by appropriate molecular testing, so we don't submit patients to unnecessary surgery, inappropriately aggressive surgery, or unnecessary diagnostic surgery. I think those things are key. And again, ThyroSeq version 3 fits right in the middle there along with good cytology. It didn't matter quite so much in the past when we took a cookie-cutter approach to managing thyroid cancer. Everybody with thyroid cancer in the 1990s and early 2000s had a total thyroidectomy, a central neck dissection, lateral neck dissection if they had abnormal nodes. Everybody got treated with radioactive iodine at some level, and you could choose lower or higher dose, but most people said if a little is good, more must be better. Everybody got suppressed TSH, everybody had standard follow-up. This was just a standard approach. Maximum tolerated therapy is the oncologic term. Maximum tolerated therapy. And that's what we had been doing for years. And in your travels, you'll still see people managing patients this way, maximum tolerated therapy. You can inform them the pendulum has swung away from maximum tolerated therapy according to all of the guidelines from ATA, European Endocrine Society, ACE guidelines, NCCN guidelines, all of them. The pendulum has swung from maximum tolerated therapy to minimum necessary therapy. And ThyroSeq can help to drive that process in a way that's safe for patients. But it certainly used to be easy. You could do the surgery, do the radioactive iodine, suppress the TSH, do the whole body scans, stimulate the thyroglobulin, we could all be happy, go home rich and happy and healthy. And of course it does work, but it does make you question why we would do that to this poor young woman who had Graves' disease and an incidentally discovered 1.5 millimeter papillary microcancer, which was of no relevance to her health whatsoever. Compared to this guy who has deeply invasive follicular thyroid cancer threatening his life within the next 6 months to a year. Those two people don't deserve the same treatment. They don't deserve the same worry. They deserve to be treated individually in a precision medicine way. And it's not just because of the imaging, it's also about the disease, it's also about the underlying genetics that drive the disease. So the idea of a precision approach to this is to avoid the over-treatment of patients who don't require and can't benefit from aggressive therapy, because most of our patients actually have low-risk disease that can be managed with less aggressive approaches. But we should also identify those patients at high risk of disease, high risk from their cancer, okay, so that those individuals can be targeted for more aggressive treatment up front and more aggressive surveillance and more aggressive treatment downstream. There's nothing worse than a patient being told, it's a good cancer, okay, and they've got a negative whole body scan, so they must be cured, and then 6 months later they're representing with huge lumps in the neck, which quite frankly we could have predicted because their surgical treatment was incomplete and it was never a cancer that was going to concentrate iodine. And I see that every single day. So we've got to recognize that thyroid cancer is a spectrum disease, from very indolent to very aggressive. And it's very important we know where on that spectrum the patient lies, whether it's in the early diagnostic phase, the post-operative phase, or during the surveillance and follow-up. What this precision approach also promises is to avoid over-investigation in patients at low risk, avoid under-evaluation of patients at high risk, even once their surgery is done. And what we're trying to do really is to balance the risk and benefit so that the punishment fits the crime, whether it's in the diagnostic end of this, the treatment end of this, or the surveillance and monitoring end of this process. And so we know that there's a number of factors before we even get to cytology and histology that can tell us and guide us a little bit about how we should be approaching things. Older patients do less well with thyroid cancer. If you're a 20-year-old, you're going to live forever, even if you have a papillary thyroid cancer. If you're an 80-year-old, that cancer could kill you because age is a major prognostic factor. Men tend to do a little less well than women. You could argue how important the gender is, but it is supported by several studies. And of course, we have the potential for immunosuppressive drugs these days being used for a variety of different things, allowing cancer to blossom and grow. That's controversial, but worth thinking about. I've mentioned already the type of cancer matters. Everybody's worried about Hurthle cell cancer. Hurthle cell cancer mortality rates are in orange. Excuse me. They are no worse than follicular thyroid cancer. This idea that Hurthle cells are bad for you is not supported by the data. Okay, so that's another important learning point for physicians. Follicular cancer, Hurthle cell cancer is real cancer. Mortality rates overall around 30% in the old data, but it's not any worse for Hurthle cell than it is for follicular. Papillary cancer overall is not a devastatingly deadly disease. Only about 6 or 7% of patients with papillary cancer die of that cancer, but it is a pain in the neck disease because it has a troubling tendency to remain in lymph nodes in the neck and to recur downstream and literally cause a pain in the neck, which is how I describe it to my patients. Anaplastic thyroid cancer, on the other hand, that gets even my oncologist's attention down at the cancer center, because when I say the mortality rate is 95% within 1 year, that catches everyone's attention. Anaplastic is a deadly disease. And very interestingly, papillary cancer, unique mutational profile. Follicular and Hurthle cell cancer, unique mutational profiles. Anaplastic thyroid cancer, a genetic mess. Okay, so again, genetic testing underpins the histology and can help to clarify prognosis and therefore direct treatment. It's worth you being aware, without necessarily knowing all the details, that the staging system for thyroid cancer is changing right now. And what used to be called stage 3 disease in patients between 45 and 55 is now stage 1 disease. What used to be called stage 4A disease in that 45 to 55-year-old age group is now called stage 1 disease. Okay? So things have changed a lot. And just to get to the crux of the matter, 45 is no longer the cutoff where thyroid cancer becomes bad for you. Okay, it used to be if you were diagnosed on your 45th birthday or afterwards, it was regarded as bad disease. If it was the day before your 45th birthday, it was not bad disease. Okay? Now, of course, that was never a realistic construct, and all we've done is to shift it from 45 to 55, so it still counts on your 55th birthday. But it takes a whole chunk of people out of the running for stage 3 and 4 cancer. They can only actually have stage 1 or 2 when it comes to follicular, papillary, or Hurthle cell cancers. Okay? And that's the new staging system here, and this will be available to you if you are interested. But again, one of the reasons for thinking about this is because this again supports this idea of the pendulum shift away from maximum tolerated therapy towards minimum necessary therapy in a much broader range of patients with thyroid cancer. And that, of course, applies whether it's cytology proven cancer or whether it's Bethesda III or IV. This staging system does work. The new staging system gives nice clarity. If you have a stage 1 disease, you're going to have a much better overall survival than if you have stage 4 disease. That's what you hope for with a TNM staging system, and so this system does work. But what's really key is beyond that initial staging, what happens to the patient over time? And one of the things that we have learned is that if we have a high-risk patient who responds really well to treatment, their overall risk drops down and they become less and less at risk for recurrent disease in the future. If you have somebody with apparently low-risk cancer to begin with, but who doesn't respond to treatment because the surgeon didn't take it all out or they turn out not to be responsive to radioactive iodine, that patient may technically have low-risk cancer to start with, but it's going to grow and it's going to become high risk over the future. And so this is called adaptive risk assessment. And once again, it's part of that process of getting more precise about how we approach the management of patients with thyroid cancer. And this concept, I believe, is helpful as you approach physicians wherever they are on the spectrum of managing thyroid cancer. Now, when it comes to ThyroSeq, it fits solidly into that pattern of understanding the nuanced approach, precision approach to cancer care and diagnosis. Risk of disease recurrence does not depend exclusively on stage. It depends on a whole variety of different things. You will see in here that BRAF status, which ThyroSeq assesses, is included in the risk assessment from the ATA. So do other mutational profiles, and increasingly mutational profiling will be part of the follow-up recommendations and the adjuvant treatment recommendations. Right now, interestingly, although the ATA says if you know BRAF status, you should use it in the assessment, it doesn't require you to get BRAF status amongst your patients. Okay? That's likely to change over the next few years so that increasingly we will be using molecular profiling, not just at the diagnostic end of this journey, but as part of the staging system and the prognostication system and changing the follow-up of your patients. So we're on the cusp of that technology making a difference across the spectrum of this disease, not just at the diagnostic end. So here's an individual case. This is another woman with a right-sided thyroid nodule. For some reason, all of my nodules are right-sided ones. I don't deal with left-sided nodules. This woman in the past would have been recommended for a total thyroidectomy for any kind of cancer in there. Now the total thyroidectomy is recommended only for large disease or deeply invasive disease. And even people with minimally invasive disease, so-called T3 tumors, where that cancer is out of the thyroid and into the surrounding tissues, even that, these days, it's okay to just take that half of the thyroid gland out according to ATA. So a minimal intervention. After a lobectomy, completion thyroidectomy is not going to be necessary according to the ATA if the nodule is less than 4 centimeters. That's a pretty big nodule. And it's otherwise low risk by histology. I would add into that low risk also by molecular profiling. And so again, right now we're only playing in the indeterminate cytology space, but over time this is going to be expanding into the evaluation of the cancers as well. So this is just beginning to open the door towards that. And most importantly, minimum necessary therapy, minimum surgery, minimum intervention with radioactive iodine, and minimum harm to the patient in adequately treating their cancer. So according to ATA guidelines, precision approaches recommend minimum necessary therapy. Surgery, even for an established cancer that's otherwise low risk, can be lobectomy alone. Okay, that would not apply right now to the V600E BRAF mutation, where total thyroidectomy would be recommended. So again, your test is giving us that information. Adjuvant therapy is recommended with radioactive iodine only in select cases. But very clearly, in order to apply precision approaches to treatment, you have to have precision diagnostics beforehand. There's no point in saying you could have done a lobectomy when the surgeon's already done the total. You can't put that thyroid back in. Okay, so the precision approach to diagnosis is key. So identifying benign nodules that can safely avoid surgery is key. That's what cytology was invented to do, and it does it remarkably well. When you've got indeterminate cytology, we have ThyroSeq available. If there are no mutations in a cytology that's Bethesda 3 and 4, we have changed our approach at Moffitt, and we do not take those patients to the OR unless there is some significant reason to do so, whether it's local compressive symptoms or something else abnormal. But otherwise, we don't take those patients to the OR because this technology is now well established and proven. Identify pre-malignant nodules. I've mentioned the RAS mutations already at some length. Identify those pre-malignant nodules and offer the opportunity for thyroid lobectomy, the minimum necessary surgery for that. It is not a false positive, it is a true positive. It's just not true positive for cancer. Identify low risk versus high risk cancers and offer optimal surgery for those cancers. And if it's a V600E BRAF mutation, realistically, that patient's going for the total. In the presence of a RAS mutation, they're going for a lobe. So the granularity of information is really a key point for ThyroSeq.
So are you requesting ThyroSeq for category 6?
Not yet, except as part of an experiment.
So how do you identify the low risk versus high risk?
Right now, we're doing it the old-fashioned way, with the size of the nodule and with the imaging of the lateral neck and central neck. I would love to be applying molecular technologies to that. Right now, that's not covered under any of the healthcare plans that I'm aware of. If we were trying to do that, it would be, patient pay. So we're doing it as part of a study along with Uri to identify whether there is added value there. So this is an aspirational goal rather than an expectation right now. On the other hand, if I have a Bethesda 3 that happens to have a V600E mutation, as we have a few, then it's nice to know that because then I can tailor the surgery the right way. Similarly, if I have a TERT and P53 overexpression along with a RAS, then that allows me to tailor the surgery to a more extensive surgical procedure. Yes?
So what would you do when you walk into an institution that doesn't use the Bethesda?
Tell them to use Bethesda. Educate them. Tell them to send the pathology to CBL. At the end of the day, people have to step up to the plate. So at Mayo, they don't use Bethesda. Okay, and actually one of the reasons that I'm not at Mayo anymore was because I really felt that institution needed to step into the 21st century. They had used a system that was kind of a quasi-Bethesda system, and to be fair, they at least had good information, some of the best information about what the probability of malignancy was in each of their categories. So that's okay. But most institutions don't have that information. So if they're not using Bethesda, it's really hard to interpret what the results mean. Very, very hard to apply any kind of molecular testing to that because of the impact of pre-test probability on the performance of the molecular test. And so that's where your role in educating those individuals about why they need to use Bethesda is really key. And of course, you can offer them opportunities like overreads. You can offer them opportunities like other people coming along to advise them. But you have to take people on the journey. And quite frankly, you're never going to sell 100% of the punters every single time. So there has to be some dropouts. And the dropouts will come along later on in the journey.
What about institutions that aren't sending Bethesda 5?
So Bethesda 5 is a complicated category because it has, again, a broad range of malignancy within it. In our experience in-house at Moffitt, the only things that go into our Bethesda 5 are highly suspicious with about a 90% plus probability of cancer. So in those individuals, we are actually not sending ThyroSeq for Bethesda 5. At Mayo, Bethesda V had more like a 50% probability of malignancy and included a whole bunch of things that were likely NIFT-P, minimally invasive, whatever. There, it would actually be useful to send ThyroSeq for Bethesda V. So it's going to be institution by institution. It's going to be pathology group by pathology group, whether that Bethesda V really makes sense.
Can you just expand on that a little bit as far as the pretest probability of malignancy? Like at Moffitt, you're saying yours is way higher, and why is that compared to?
Because we're selective about what gets called Bethesda V. You have to have a lot of features that really suggest cancer before our pathologist will call it Bethesda V.
But if everyone's using the Bethesda system, then shouldn't it be the same?
Unfortunately, I would defer to Dr. Urmacher on this point, but there's no question in my mind that cytology is an art form, and the artist will modify the painting to some significant degree. So it depends partly where the cytopathologist trained, with whom they work and what group they work in, and whether they apply, quality control standards to maintain a consistency. So when I first arrived at Moffitt, I will air my dirty laundry on video and say that we had very inconsistent cytopathology. Depending on who the pathologist was, we would get various different reads and various different probabilities of malignancy. And one of my first successes at Moffitt, after I got there, was to drive a consistency quality control process with the help of Barbara Centeno, our cytopathologist. So now we have internal consistency. And for a period of about 3 years, every indeterminate cytology was overread by a minimum of 3 pathologists. Okay, that's how we drove the quality. Now, I'm certain that at CBL, those kind of quality control measures are in place, and that's another heavy selling point when you're addressing somebody whose cytopathology is being done in a group that doesn't do much thyroid cytopathology. That quality control issue, that standardization is really critical. And I can't move past the fact that molecular testing is an adjunct to excellence in cytopathology. If you don't have excellent cytopathology, the moleculars will not make up for it because of the risk that you have a different pretest, a different input. And the old phrase in computer science is garbage in, garbage out. And if you have the wrong kind of input into molecular testing, you get the wrong output. So that's really key. But we'll embark on some more of those discussions in the second part of this presentation after the break, assuming Heidi gives us the time and Brian is kind enough to do so. So again, you're making my point here. Excellent cytopathology, nuanced molecular markers are keys to precision thyroid oncology. And I really am standing here today primarily to drive that point home, that we've got to push through the entire group of endocrinologists and surgeons the idea that this is a precision disease and that we have, a spectrum disease that requires a precision approach to managing it. And that's it for this first little half of this talk. So I thought we could take just a very few questions, Brian, if that's okay, and then have some coffee because I'm dying here, and then we can do the second half after. Okay? Pressing questions right now. Thank you.
Maybe I'm jumping ahead a little bit here, but I've had a couple people recently say things about ThyroSeq version 3's false negatives, and my comeback to that was that they were intrathyroidal, they were non-aggressive histology, but I don't have anything else, and I don't know.
So there is no such thing as a perfect test.
Right.
Whichever test we use, whether it's cytology, whether it's histology, whether it's molecular testing of any sort, there's going to be a small number of patients who come out as negative but actually have the cancer. And in the case of ThyroSeq version 3, as we'll discuss in this next session, some of it is because we don't know all of the mutations that drive thyroid cancer. In the case of the VeriCyte test, it's because the way the classifier was trained didn't require it to identify all the cancers. Okay, and so any one of these tests has some degree of false negative. So the negative predictive value of, say, 96% means that 4% of the cancers will be missed. Okay, numerically, that's very small numbers, and it's not a big disaster because you're going to be following those patients anyway.
And that's the same as benign.
And it's the same as benign cytology. So in the meta-analyses that have been published, benign cytology has a residual risk of cancer, a missed cancer rate of 6%. Okay, now that's probably an overestimate from good cytology, but nonetheless, in that same kind of 5% range roughly, benign cytology negative molecular markers, whether it's Verocytes or whether it's ThyroSeq, all of these have a low but real risk of missing a cancer. So anytime you're dealing with a thyroid nodule, the key is to track and monitor that nodule, even when the cytology is benign. But I would say especially when the cytology is not benign, but the molecular markers are. Then under those conditions, we just watch them a little more intensely and do the follow-up. Now, to the point you made, there's an additional issue there, which is the vast majority of those missed cancers turn out to be very low-risk intrathyroidal malignancies that haven't developed a spectrum of mutations that drive the aggressive behavior. And so as a consequence, yes, it's not ideal to miss a cancer, but the consequences on the patient are low.
Do you know specifically what was missed in the ones that were false negative in the trial? And then
Yeah, because they didn't have mutations.
But they were the false negatives, they didn't have mutations?
Yeah, because there's no mutations in there, so that weren't picked up on the assay. Now, one of the nice things about ThyroSeq is it does have an adequacy step involved, and we'll talk about that in the second session too. So unlike Verocyte, and unlike any of the other molecular markers, the ThyroSeq assay actually decides whether there is enough follicular cell material to give a satisfactory read. And if there's not enough follicular material in there, you will get told that in the report. And so you can use that to determine how reliable the test is. That does not exist for Verocyte's assay, where they'll just run it on whatever DNA is in there without proving its follicular cell content. Okay.
Do you ever see ThyroSeq replacing cytopathology?
You're sitting just one step away from Dr. Urmacher. That's
You think about the GYN scenario.
yeah. So ever is a long, long time. I don't see it happening anytime soon because the cost structure doesn't make sense. You don't pay cytopathologists that much money, I think. Dr. Urmacher, you can correct me if I'm wrong on that. Yeah. But at the end of the day, you know, a pair of eyes looking down the microscope can identify benign thyroid nodules very reliably, very quickly. And even if you're using smears, you know, I think the College of American Pathologists says you're not supposed to see more than 100 slides a day, as I remember, is the cap. So that's, you know, between 10 and 15 thyroid biopsies that you can do. Even with that limitation, you can plow out the benign results pretty rapidly. And so it becomes a very cheap and cost-effective way to screen the majority of these patients. Is it possible for moleculars ultimately to replace that? Yes, if the cost structure changes. If it becomes a much more cheaper commoditized test, then that potential, of course, could exist. But I don't think the science is there yet.
One of the good applications we get from ThyroSeq generates phone calls to us saying, hey, you guys are very good, is when you find non-thyroidal disease by genetic testing, keratins with parathyroid.
Yes, that's absolutely right. So one of the nice things about ThyroSeq is it does look for parathyroid tissue. It does look, which often will, under the microscope, look like a follicular neoplasm, for example, and it's hard to tell the difference unless you're really tuned into the possibility. But it will be picked up on ThyroSeq. Similarly, metastatic disease from a variety of common sites, including kidney, I think breast, and there's one or two others. If it's metastatic into the thyroid, then that will be picked up by the ThyroSeq test as well and can give you that heads up that, hey, this is not your standard thyroid nodule.
What would that look like as far as a result, though? What would come back?
It will come back saying metastatic disease, likely of breast origin.
ThyroSeq would actually, the report
Yeah.
actually say that.
There's actually a screening step in the ThyroSeq, first of all, to see whether there are sufficient follicular cells in there. Secondly, what other cells they might be derived from. The
Housekeeping gene.
yeah, and again, we'll talk about that in the second session, if that's okay. There's just one interesting case I'll share with you as we wrap this one up, and that is a patient I saw with a very large thyroid nodule that looked pretty suspicious on ultrasound. And we did a biopsy on that thing, and it was read out as Bethesda III with atypical features. And we sent it off for ThyroSeq. It came back with a V600E mutation. It was a melanoma, metastatic to the thyroid gland. And it was when the V600E mutation came back and we pushed it back to the pathologist because we knew this patient had had a history of melanoma, and the cytopathologist read it again and said, yeah, actually we should have picked it up, it was actually a melanoma. But it was the ThyroSeq that allowed us to pick that very rare event up as part of the evaluation. And again, that patient was appropriately managed through means other than their thyroidectomy. So tailored treatment, precision approaches to the management of patients with thyroid nodules and cancer.
So in that scenario, there was a lack of thyroid epithelial cells? But
There was
V600E
exactly,
material?
precisely. It picked up low follicular content and V600E strongly expressed. And in fact, the ThyroSeq report suggested possible malignant melanoma metastatic to thyroid.